In this particular section, we are going to discuss on the growth hormone and the growth hormone excess. In order to understand what are the effects of excessive growth hormone, you have to understand the physiology of the growth hormone first, and it should be in your fingertips. So what is the physiology of the growth hormone? So again, we'll start with the hypothalamus, pituitary, growth hormone, and the related effects like how we have seen in the prolactin. And before going into the actual effects of growth hormone, let us know one important point, that growth hormone is the most abundant hormone in the body. So I can write this: growth hormone is going to be the most abundant hormone in the body. At the same time, you know the acidophilic hormones, the prolactin and the growth hormone, doesn't have any specialized target organs to exert their effects. That is also a very important point. Like you have ACTH, you have TSH, and you have gonadotropins like FSH and LH. They have some specific target organs, but the growth hormone and prolactin do not have specific target organs to exert their action. Then what about the physiology? Now we'll move on to the actual physiology of the growth hormone. So we'll start with the hypothalamus, again, which is a master to the master gland, that is the pituitary. And you have this somatotrophs that are going to secrete the growth hormone, and how the somatotrophs are controlled by the pituitary. Hypothalamus, that's what we're going to see. Remember, there are two levels of control. One is the stimulatory control or releasing control for the somatotrophs, that is coming from the hypothalamus, that is in the form of a hormone called as growth hormone releasing hormone, which stimulates the somatotrophs to release the growth hormone. And there is a inhibitory control also coming from the hypothalamus in the form of a hormone called growth hormone inhibitory hormone, that's going to actually inhibit the release of growth hormone from the somatotrophs. Now, this growth hormone releasing hormone is also referred to as something called a somatostatin. Yeah, you can understand the name somatotrophs inhibitor. That's why it's called a somatostatin inhibitor. So based on how much the pituitary receives, the somatotrophs receives the stimulatory control versus the inhibitory control from the hypothalamus, they are going to release some amount of growth hormone. And this growth hormone is going to exert the peripheral effect on the target tissues, right? So they are going to exert their effects on the target areas. So let us move back to the receptors again. So you know this inhibitory control needs a receptor, which means the somatostatin acts on the receptor, and these receptors are referred to as SSTR. That's called somatostatin receptors. And this must be GPCR, and it is G protein inhibitory type of receptors. These are GI type of receptors, which means they are going to down-regulate the cyclic AMP, and that is why they are going to reduce the release of growth hormone from the somatotrophs. And similarly, this GHRH is going to be stimulatory type, and it has to be G stimulatory type of G protein coupled receptor, which means they increase the cyclic AMP, and that is how they increase the release of growth hormone. And finally, the growth hormone itself has effects, and how these effects are mediated through a group of cell surface receptors referred to as NRTKs. We again know these are nothing but Janus kinases, and these are JAK-STAT pathway. We studied again TINS, TERS, GH, and GM-CSF are going to act through JAK-STAT pathway only, and the effects of growth hormone are mediated through JAK-STAT pathway, that is NRTKs, non-receptor tyrosine kinases. So now, understanding the receptor principles, let us move on and see what are going to be the effects of the growth hormone. You can classify the effects of growth hormone into two different ways. One is the indirect effects, and second one is the direct effects. Remember, the indirect effects of growth hormone are actually mediated through a lot of organs, and the major organ where the indirect effects are mediated is the liver, where the growth hormone acts on the liver and causes the release of a group of compounds called somatomedins. These are mediators of growth hormone. That's why it's called somato growth hormone mediators, somatomedins. The most important somatomedin, and it's coming from the liver, that is what we refer to as IGF-1, insulin-like growth factor 1. But you have other somatomedins also. What are the other somatomedins? This doesn't only come from the liver, they can come from other peripheral organs also. What are the other somatomedins? You have nerve growth factor, you have IGF-2, and you have fibroblast growth factor FGF, and you have epidermal growth factor EGF. These are the other somatomedins that are released in response to growth hormone. But always remember, this IGF-1 is going to be the most important somatomedin, and the somatomedin with highest efficacy, that is really, caused by growth hormone from the liver. And this IGF-1, you know, it is insulin-like growth factor, isn't it? And this itself is going to have some peripheral effects. And this itself is going to have some peripheral effects. And please do understand, the effects of IGF-1 will not be mediated through JAK-STAT pathway. And the effects of IGF-1 are going to be mediated through this IGF-1 receptor. And what will be the IGF-1 receptors? This IGF-1 receptor, you know, it is insulin-like growth factor, which means it has to be receptor tyrosine kinases. I told you receptor tyrosine kinases, all the growth factors except the TGF-beta I told you, and insulin act through this RTKs only. This is the insulin-like growth factor, so this is like insulin and it has to act through receptor tyrosine kinases only. These are not JAK-STAT receptors, they are receptor tyrosine kinases. Fine. Which means this IGF-1 receptor is going to be receptor tyrosine kinase type of receptor only. Okay. Obviously, the direct effects are through NRTKs, that is JAK-STAT, because these are directly done by the growth hormone itself. So what are going to be the effects? So this effects due to IGF-1 and this effects due to direct effects of growth hormone. Both have some similar effects. What are the similar effects? Both causes growth related effects. Both promotes growth related effects. How? Both increase protein synthesis and both can accelerate cartilage and bone formation. Both can accelerate cartilage and bone formation, and both can increase the epiphyseal growth as well. Epiphyseal growth. Remember, this epiphyseal growth, if it increases, that actually increases the linear growth height. And this is very specific only if you are associated with growth before the closure of epiphysis. The linear growth can increase only if the epiphysis doesn't close. If the epiphysis closes, after the closure of epiphysis, you are not going to get linear growth. But still, even after closure of epiphysis, they can accelerate the cartilage and bone growth in different areas, but they cannot accelerate the linear growth. But these are some of the effects of growth hormone directly as well as indirectly. So these are common effects. But remember, the metabolic effects are going to be different. What are the different effects of IGF-1 and what are the different effects of growth hormone? Remember, IGF-1 is insulin-like. So which means they are going to have insulin-like effect. The most important effect is they reduce the blood glucose, which means they are insulin-like. Which means the effect of IGF-1 is to increase the insulin sensitivity. They promote hypoglycemia. And the second effect is going to be they are anti-lipolytic. Anti-lipolytic, which means insulin reduces lipolysis. And definitely your IGF-1 also should be reducing the lipolysis. Okay. But the direct effects of growth hormone are different. Directly, growth hormone is going to increase the blood glucose, which means they cause reduced insulin sensitivity. or I can even write they are going to be like antagonistic to insulin, which means they are going to increase the insulin resistance. And second, they are going to increase the lipolysis. It is like anti-insulin like. I can write this is anti-insulin like action. Remember, the indirect effect is insulin like, but the direct effect is anti-insulin like. And whenever growth hormone is in excess, it is the direct effect that always wins rather than the indirect effect. So which means the anti-insulin like effect will predominate in growth hormone excess states rather than insulin like effect. Clear? Next, they can have sodium retention. Because of the sodium retention, they can also have water retention. Because of that, they can have edema. So edema formation, one of the important effects of growth hormone, direct effects. And they can have phosphate retention. And this is also one of the direct effects of the growth hormone. And how they produce this sodium retention, we have no idea. We have very little idea, in fact, probably due to activation of renin-angiotensin aldosterone system. This aldosterone is the main reason for this sodium retention, probably. So that is how they work. And this is the entire physiology of growth hormone. And do remember, this growth hormone again has multiple inhibitory signals. Growth hormone release has multiple inhibitory signals. There are a lot of things that can inhibit the growth hormone release from the somatostaphs. At the same time, you can have multiple stimulatory signals to release growth hormone from the somatotrophs. And first, let us finish off the inhibitory signals. The first inhibitory signal, obviously, is going to be somatostatin through the somatostatin receptors, the most important. There are a lot of other hormones that can work to reduce the growth hormone release, that is cortisol. Next is patients who have hyperglycemia. Remember, this hyperglycemia has multiple effects. Hyperglycemia itself will increase the somatostatin. Because of that also they can reduce the growth hormone release. And number 4, fatty acids. Remember, proteins will increase the growth hormone release, but fatty acids will actually decrease the growth hormone release. Now, what are the conditions or what are the stimulus that increases the growth hormone release? Number 1, any form of stress like emotion, fever, surgery, trauma, exercise. So any kind of stressful events might increase the growth hormone release. And number 2, hypoglycemia, like how hyperglycemia reduced growth hormone release. Similarly, hypoglycemia is a very, very important entity that's going to increase the growth hormone release. Next, protein meal and excessive amino acids in the circulation. Like how fatty acids inhibited growth hormone release, similarly amino acids and protein will try to increase the growth hormone release. And sleep, especially early part of the sleep. I'll come back to the sleep. Remember, in the first 4 hours of sleep, growth hormone will increase. That is, early part of sleep, growth hormone tends to increase. But in the later half of the sleep, growth hormone levels tend to decrease actually. And probable reason for this is REM sleep. So now we can assume that probably the REM sleep will actually reduce the growth hormone release. But NREM sleep, which means the early part of sleep has more NREM, later part of sleep has more REM. So REM and late part of sleep will reduce growth hormone. Early part of sleep and NREM may increase the growth hormone release. But what are the effects of sleep deprivation? Sleep deprivation is going to increase the growth hormone, because sleep deprivation itself is a stressful event to the body. I told you any form of stress is going to increase the growth hormone. So sleep deprivation will increase the growth hormone release. Okay. Then I can write sleep deprivation. Some hormones like ghrelin, some other hormones like ghrelin and glucagon, how cortisol reduce the growth hormone release. Similarly, ghrelin and glucagon can increase the growth hormone release. But this is very, very important, ghrelin, because we use one test in hypopituitarism, isn't it? Massey-Morlin test. where we actually use this principle of ghrelin-induced excessive growth hormone. If you give massive morlin, ghrelin will increase. But if increased ghrelin is not associated with increased growth hormone, after giving massive morlin, we can tell that the patient is having growth hormone deficiency. One way to diagnose a growth hormone deficiency. Fine. So these are the physiology of growth hormone. You have to know. Then we can move to some other small physiology. Like I told you about the sleep already, but how the growth hormone are released in general. Remember, growth hormone is released in pulses, that it is pulsatile in its release. Pulsatile means each pulse will last for 90 minutes. One pulse will be lasting for 90 minutes and there will be a gap of 120 minutes, that is 2 hours, and then which will be followed by another pulse for 90 minutes. So like this, how much pulses are released? Approximately 10 pulses per day. In 24 hours, 10 pulses of growth hormone will be coming. And one more interesting thing I didn't tell you, that this somatostatin receptor are of many types. This SSTR of many types of SSTR are there. You have somatostatin receptors type 1 to 5. In that 2 and 5 are the most important receptors as far as pituitary is concerned. If they ask you which of the somatostatin receptors are not well described in pituitary, answer is receptor number 4. Somatostatin receptor 4 is not expressed by the pituitary in high amounts, where it is expressed in high amounts in the GIT but not in the pituitary. But in the pituitary, receptor number 2 and receptor number 5 are the most important. Clear? So these are the receptors that regulate the growth hormone release. So with this we can finish the physiology of growth hormone and we can move on to what are the causes of growth hormone excess. We all know growth hormone excess has different effects in children. Before the closure of epiphysis, they are going to result in pituitary gigantism. Whereas in adults, after the closure of epiphysis, they are going to result in acromegaly. But please do understand, for both these gigantism in children as well as acromegaly in adults, the most common cause is going to be growth hormone secreting pituitary adenoma, which means for any condition that causes growth hormone excess, any time you see a growth hormone excess, the most common underlying cause will be growth hormone secreting pituitary adenomas. These growth hormone secreting pituitary adenomas are also referred to as somatotroph adenomas. Somatotroph adenomas. Clear? Which means, if I tell you the most common causes growth hormone secreting pituitary adenomas, there must be a lot of causes for this growth hormone excess. So that's what we're going to see next. What are the causes for growth hormone excess? They can be divided into 2 categories. One is those that they actually increase the growth hormone, and second one, those that increase the growth hormone releasing hormone, because of that you will have excessive growth hormone. Clear? So again, growth hormone excess, the usual reason for growth hormone excess again can be divided into primary growth hormone excess, that is usually due to pituitary dependent or pituitary causes, or even it could be due to secondary growth hormone excess, that is due to ectopic release of the growth hormone, not from the pituitary. So primary pituitary related growth hormone excess, again the cause will be due to a pituitary adenoma or a somatotroph adenoma, or otherwise referred to as a growth hormone secreting pituitary adenoma. Correct, isn't it? So remember, this is the most common cause for growth hormone excess overall. More than 90 to 95% of the cases of growth hormone excess is due to somatotroph adenoma only. It is usually sporadic, but it can happen in some familial conditions also. Familial means the first thing that should come into your mind is a MEN1 syndrome. Clear? In MEN1 syndrome, most common tumor, pituitary tumor, is prolactinoma only, but the second most common pituitary tumor or a functioning pituitary tumor is growth hormone secreting pituitary adenoma. That's why this point is important. And second, it can happen with an endocrine syndrome called a Carney complex, or it can also happen with another endocrine syndrome called as McCune-Albright syndrome. You know, McCune-Albright syndrome is a triad. What are the components of the triad? The first one is a hyperpituitarism. Usually they will result in precocious puberty. They might also be associated with growth hormone excess. Second, they might be associated with Caffioli spots. And third one is the fibrous dysplasia of the long bones, especially of the femur, which might result in the classic Shepard-Crook deformity. So this is McCune-Albright syndrome, triad of precocious puberty, Caffioli macules, and fibrous dysplasia of long bones, or a polyastotic fibrous dysplasia, or ectopic growth hormone excess, which means what are the conditions that produce ectopic growth hormone? Ectopically, growth hormone can be seen in excessive state, secrete excess from a pancreatic neuroendocrine neoplasm, or it could be from a small cell lung cancer, or it can happen from a medullary thyroid cancer, or it could be very rarely due to iatrogenic growth hormone administration. But remember, these are the three tumors that will once again come here also, because that's why I can actually duplicate it and I can write, because these are the same three tumors that are going to produce this excessive growth hormone releasing hormones also peripherally. Very, very important. These are also one of the important peripheral causes of growth hormone releasing hormones. Why these tumors are actually producing excessive growth hormone? So especially this pancreatic neuroendocrine neoplasm and small cell lung cancer. Let us see. There is a group of cells, embryologically these are referred to as neuroendocrine cells, and these neuroendocrine cells migrate to different areas in the body, and they produce a lot of different hormones in that particular area. Some examples I'll tell you, even though the best explanation I'll be giving you in the GIT section when I'm going to discuss on the carcinoids and the pancreatic neuroendocrine neoplasms, but right now just understand in a very simple way. For example, they can migrate to the pituitary, where they form cells of the anterior pituitary, that is adenohypophysis, and they secrete hormones from that area. Similarly, they can go to the pancreas, where they form the different islet cells and they can secrete different hormones like insulin, glucagon. Or similarly, they can go to the lungs, and where they have different function. Suppose if you have a tumor in the pituitary neuroendocrine cells, this is what we refer to as a pituitary adenoma. Tumors of these neuroendocrine cells in the pancreas, we are going to call it as pancreatic neuroendocrine neoplasms, and a malignant tumor of the lungs is what we refer to as a small cell lung cancer of the neuroendocrine cells of the lung. So sometimes if the tumor is extremely malignant, the property of a malignant tumor is to de-differentiate, and maybe they can re-differentiate and go to the more primitive cell type. That's what a feature of a cancer is. So they can de-differentiate and they can become more primitive neuroendocrine cells, and they can start secreting different hormones of the pancreas, or they can even start secreting different hormones of the pituitary, acidophils or basophils. So that's how a small cell lung cancer can secrete an ACTH, because they have the same root, same origin, that's neuroendocrine cell origin. Similarly, a pancreatic neuroendocrine neoplasm can de-differentiate and they can start secreting a pituitary hormone. That's why I told you, it will come under growth. They can produce excessive growth hormone, or they can produce excessive growth hormone releasing hormone also. So what about this MTC? Medullary thyroid cancer. This is a very important point again. Why? Because you would have studied a lot of thyroid cancers where they usually do not produce paraneoplastic syndromes. Take a papillary thyroid cancer, which is the most common thyroid cancer. They are not going to produce that much paraneoplastic syndromes. Follicular thyroid cancer, no, not that much. In fact, not at all. Anaplastic, no. MTC, yes. Lot of PNS, paraneoplastic syndromes, are seen with medullary thyroid cancer. If they ask you the usual thyroid cancer with excessive paraneoplastic syndromes, or the most common thyroid cancer with paraneoplastic syndromes, answer is medullary thyroid cancer. That's why that point is very important. So now we have discussed on the causes of growth hormone excess also. These are peripheral causes of growth hormone releasing hormone excess. But there are some central causes of growth hormone releasing hormone excess. What are the central cause of GHRH excess? Very, very, very rare causes. Number one, you can get with a hypothalamic hamartoma. This hypothalamic tumor that secretes excessive growth hormone. So hypothalamic hamartoma is associated with precocious puberty, sometimes excessive growth, and they are associated with a very peculiar type of seizures called gelastic seizures. You know that gelastic seizures are nothing but seizures that are associated with uncontrolled emotions like uncontrolled laughter or uncontrolled crying. So this is what we call as gelastic seizures, and hypothalamic hamartoma is a very notorious cause of it. And number two, it can be associated with another type of a tumor called a ganglioneuroma. So these are the different causes of this growth hormone excess. But ultimately, how much ever causes you tell, it breaks down to only one cause. The most common cause of growth hormone excess must be a somatotroph adenoma or a growth hormone secreting pituitary adenoma. Clear? After knowing all these things, I'm going to tell effects of growth hormone excess, and we are going to discuss on acromegaly. So that's what I want, because growth hormone excess in a child is going to result in pituitary gigantism, whereas in adults, that's what I want, is going to result in acromegaly. What is acromegaly and what are the features of acromegaly? So if they ask you the mean age for diagnosis of acromegaly, it is approximately in the age group of 40 to 45 years. And the most common cause, you know, how much ever times I tell, it doesn't change, it is somatotroph adenoma. That is a growth hormone secreting pituitary adenoma. Remember, since it's the most common cause, you have to know this, 90 to 95% of the acromegalies are due to this somatotroph adenomas only. And please do remember, 40% of the somatotroph adenomas tend to have this GS alpha mutations, which means they tend to harbor this GPCR mutation, that is G protein coupled receptor, the subunit, that is G stimulatory subunit, alpha subunit mutations. There are 4 diseases that are associated with GS alpha mutations, which we'll discuss in some time. But one among them is somatotroph adenoma. That is a result of GS alpha mutations, but 40% of the cases, not all. Fine. And acromegaly, as a disease, it tends to be extremely insidious, in the sense the median time for the onset of symptoms to the time of diagnosis is going to be almost 12 years. So it is extremely insidious, very slow, like in symptom progression and the time of diagnosis. And what are going to be the clinical features? Clear? The clinical features are predominantly going to be due to hormonal effects. The hormonal effects will be due to excessive soft tissue growth. These are nothing but the growth effects, and the growth effects and metabolic effects both are there with that. So we can see first the growth effects, and second one, metabolic effects. Remember, metabolic effects are not that great, but the growth effects are the ones that you have to definitely remember. So what are the growth effects? Growth effects can be seen in the soft tissues. Growth effects can be seen over the bones and joints. Bones and joints. And the growth effects can be seen on the organs also. And metabolic effects only on 2, glucose and phosphate typically, and maybe RAS and sodium retention. So we know that, so that's not that important right now. So now let us see on the soft tissue growth effects. So growth hormone is going to cause excessive soft tissues in a lot of areas. So number one, I can tell hyperhidrosis. Hyperhidrosis. Hyperhidrosis, that is due to sweat gland hypertrophy. Sweat gland hypertrophy and excessive sweating, and because of that the patients might have a malodor or a bad odor when you go nearby them. Remember, this hyperhidrosis is considered as the most common symptom of growth hormone, or the earliest symptom of growth hormone excess. So you have to know this for sure. Many textbooks give this fact. And number 2, they can have increased shoe or ring size, and even glove size. This is really important point, this increased shoe or ring size, and this is the usual question that goes towards growth hormone excess in a lot of MLE questions. So excessive increasing shoe size or increasing ring size or increasing glove size. That is again due to hypertrophy of the soft tissues in the hands. Even bones will get a little bigger, though that's also one reason, but typically due to hypertrophy of the soft tissues in the palms and the soles, in the palms. Clear? And because of the same reason, excessive soft tissues in the soles, you can result in increased heel pad thickness. Increased heel pad thickness. So what is the definition of increased heel pad thickness? By definition, it should be more than 33 millimeter. This is the definition. Normal heel pad thickness is less than 21 millimeter. That is normal. If it's more than 23 millimeter, that forms the definition of increased heel pad thickness. Remember, this increased heel pad thickness is not specific for growth hormone excess. It can be seen in a simple pedal edema also. Long-standing pedal edemas, it can be seen with patients who are having phenytoin therapy, patients who are having mixed edema due to hypothyroidism. So, a lot of conditions can produce this excessive heel pad thickness. Okay. So, then they can go for hypertrophy of the laryngeal muscles and laryngeal cartilage. Because of that, they can have deepening of voice. Very important feature. And because of hypertrophy of the pharyngeal soft tissues, they can go for obstructive sleep apnea. And because the hypertrophy of the soft tissues in the tongue and the mouth, they can go for macroglossia. Macroglossia. All these are due to soft tissue hypertrophy, and these are effects of growth hormone excess. And next, let us move on to the hypertrophy of the bones and joints. Remember, this hypertrophy of the soft tissues in the wrist area may even result in a carpal tunnel syndrome. And they can also result in hirsutism. Obviously, hirsutism is a feature of females, not males. Fine. Bones and joints. Bones and joints, again, lot of areas, these bones may get hypertrophied because of growth hormone effects and IGF-1 effects. So they can have enlarged nose, they can have enlarged forehead, they can have enlarged jaw. So because of the enlarged forehead, that is what we call it as something called a frontal bossing. And because the enlarged jaw, they can result in an entity called prognathism. Clear? That is also one reason. And next, they can result in dental malocclusion. Dental malocclusion. That is because the enlargement of the maxilla and the mandible, so they be widened. Because of that, the teeth may be irregular and they may be completely like out of alignment. So that's dental malocclusion. And they can also result in enlargement or widening of the sinuses. The facial sinus also will get big, which means they have increased pneumatization, more air in the sinuses. That's also one of the features of growth hormone excess and acromegaly in adults. And they can result in a condition called hypertrophic arthropathy. It's a very peculiar condition, that's hypertrophic arthropathy. What is hypertrophic arthropathy? That is due to excessive cartilage and the synovium. Excessive cartilage and the synovium growth in the joint spaces. Remember, you have a joint and you have an articular cartilage, isn't it? In between, that is radiolucent. But what can happen is, because this cartilage becomes thicker and thicker, they might result in actually more cartilage and more synovium, which means they can have widening of the joint space. Usually, majority of the arthritis and arthropathy will have narrowing of the joint space, and this is one peculiar arthropathy. That is why it's called hypertrophic arthropathy, that can cause widening of the joint space rather than narrowing of the joint space. For the same reason, the bone, because the increased bone growth, they can result in increase in size of the terminal tufts of the phalanx. Terminal tufts of distal phalanx, especially in the fingers. So, suppose if this is a normal distal phalanx, okay, this is a distal phalanx, what can happen is this terminal tufts can widen and they can result in widening of the terminal tufts of the distal phalanx. This is what we refer to as a spade-shaped or spade-like distal phalanx. Again, this is a very, very important word and a multiple times asked question. Spade-like distal phalanx. Where will you see? This is seen in acromegaly. Remember, this hypertrophic arthropathy may not affect only the, like these areas. They can affect the knee joints and they can also affect the spine, causing kyphosis. So kyphosis also a feature. You can get kyphosis and it can affect the knee joint as well as the spinal joints and can result in kyphosis. Okay, so these are some of the effects of growth on bones and joints. There are some effects on the organs also. What are the organic effects? Number one, they can have thyromegaly. Thyromegaly. They can have enlarged kidney size. The kidney size may be increased, but we don't know what is the effects of this. But there is no effects literally. These are benign problems. But one important problem is that is cardiomegaly and LVH. This is not a benign thing. The cardiomegaly and LVH actually increase the risk of cardiovascular mortality in these patients. And they can progress towards cardiomyopathy also. And they can even progress towards cardiomyopathy. Very, very important. And one other reason for this left ventricular hypertrophy and cardiomyopathy in these patients is the metabolic effect that produces hypertension. Hypertension is one important cause. That is another cause that predisposes to development of cardiomyopathy, cardiomegaly and LVH. Clear? But we'll come back to that. Apart from that, they can result in excessive risk of colonic polyps and colonic diverticulosis, and they tend to have increased risk of colonic cancer and esophageal cancer. Very, very, very important point. So they increase the risk of colonic diverticulosis. These are the crunch points that you have to know. These are the points that differentiate you from others. So the growth hormone is going to increase the risk of colonic diverticulosis and increase the risk of cancers also, colonic and esophageal cancers. Apart from that, let us see what are the metabolic effects. Metabolic effects can be on the glucose, where they tend to produce insulin intolerance, which can range from simple glucose intolerance. I cannot call insulin intolerance, I can write insulin resistance, because it can result in a simple glucose intolerance or even a frank diabetes mellitus. That is also possible. Apart from that, they can have effect on phosphate metabolism, where they tend to produce hyperphosphatemia. Very important. Multiple times asked question. These are the crunch areas again which give you an edge. Hyperphosphatemia due to growth hormone excess. And they can produce sodium retention probably due to RAS activation. So this can result in edema and volume overload state, and they can result in hypertension also because of this RAS activation. They can result in hypertension. So you can see these patients are suffering from obstructive sleep apnea. They can suffer from OSA. They can suffer from this LVH, cardiomegaly and cardiomyopathy. They can also have diabetes and hypertension and RAS activation. All these things predispose. And at the same time, they can get these cancers also, which means growth hormone excess is associated with excessive mortality for sure. No doubt about it. In fact, 2 times more mortality compared to that of the age-matched controls in the general population. So that is the reason why the treatment is a little different for growth hormone excess compared to that of hyperprolactinemia. Hyperprolactinemia does not cause excessive mortality like this. But growth hormone excess, yes, it does have excessive mortality. Clear? They ask you most common cause of death, that's very important. Again, most common cause of death in growth hormone excess is due to cardiovascular mortality. MI, in simple terms. That's the usual cause of death. And one important effect of growth hormone excess that I didn't tell you is the headache. Headache, very, very important effect. So you can ask me, sir, this is a tumor. Obviously, if it's a macroadenoma, you told it's very insidious, which means it grows to a large size before presenting. So which means it itself can produce an headache. No, I'm not talking about that. A macroedema can cause headache due to mass effect as well, but as far as growth hormone secreting pituitary adenomas are concerned, even a microedema can produce an headache, which means what I'm trying to tell is this headache is independent of the tumor size. Independent of the tumor size. Clear? This is probably due to, like excessive proliferation of this choroid plexus which produce CSF. Probable reason why they develop this headache in growth hormone excess is probably due to excessive proliferation of this choroid plexus. Because of that, they can produce excessive CSF. And because of that, there might be slight increase in the ICP, and that might be the probable reason for the headache. It's not like other tumors, only macroadenomas cause headache. Even a microadenoma and a growth hormone second pituitary adenoma can produce headaches. That is probably due to this excess CSF production due to proliferation of the choroid plexus. And what is the evidence for this? Because almost a few sizable number of patients with acromegaly can progress towards idiopathic intracranial hypertension, previously called as benign intracranial hypertension, otherwise referred to as pseudotumor cerebrae, but current term is idiopathic intracranial hypertension. Not all patients, but a sizable number can progress to idiopathic intracranial hypertension. For the same reason, I'd have told the most common side effect in children with growth hormone replacement therapy is headache again. That is again due to this problem only. So which is very clear, growth hormone excess itself can result in headache, not because of a macroedema causing mass effect. It can produce headache, all right, but the headache in growth hormone excess is independent of the size of the tumor. That's what you have to understand. Clear? Very important point. These are the different clinical features. Now, let us see some of the important images with regards to the clinical features. You can see here the patient is having a very coarse clinical feature. At the same time, you can see this patient is having a frontal bossing. Along with that, you can have a prognathism. You can see that. You can see the frontal bossing, prominent supraorbital ridges, prognathism, and the very prominent nose. All these things are classical. And you can see this is the hand of a normal individual, and this is a hand of a acromegalic. You can see that size difference. And this image, is from a patient of acromegaly only. It's to show the dental malocclusion, which is a very common thing even in general population, malalignment and malocclusion. But to show that this point is important, I have showed an image. That's all. This is a normal terminal phalanx, you can see, and you can see this is a spade-like distal phalanx. So this is a spade-like terminal part of the terminal phalanx that is due to proliferation of the terminal tuft, distal portion of the distal phalanx. And this is to show that you can see such a big sinus. This is due to over-pneumatization of the sinuses and enlargement of the sinuses in the face. So one reason why you get this coarsening of the facial features and like big face and with all this frontal bossing and all these problems. And this is to show this patient is having increased heel pad thickness. More than 23 millimeters is the definition, I told you already. So these are some of the images that you have to know. Now let us move on to the workup and diagnosis of growth hormone excess. Suppose if you are suspecting a growth hormone excess, what you have to do? So first test you prefer here is the serum IGF-1. So that's the first test you are going to prefer, serum IGF-1. So this is actually considered as the screening test of choice. So this is considered as the screening test of choice for growth hormone excess. So suppose if the IGF-1 levels are normal, you can rule out growth hormone excess. If the IGF-1 levels are increased, because IGF-1 levels that are increased doesn't have that much specificity, but it's very sensitive. They don't have that much specificity, so you have to confirm. How you are going to confirm the growth hormone excess? The growth hormone excess can be confirmed with a lot of suppression tests. Confirmed with suppression tests. So what is the suppression test that you're going to use is nothing but your OGTT, oral glucose tolerance test. I'm not joking, it is OGTT only. That's how you're going to confirm. So how you can tell that OGTT can confirm. I told you already, somatrophs produce growth hormone, and this growth hormone is one of the direct effects and the principal effects of growth hormone is to increase the glucose. And this increased glucose itself can act as a negative feedback to the somatotrophs, thereby neutralizing the growth hormone release and thereby neutralizing the glucose also. So this is some feedback that is going on. It's a negative feedback. Now, what I'm trying to do is, you know that very well, this glucose is going to act as a very powerful negative feedback for the somatotrophs. So I give glucose, from externally, I can produce a hyperglycemia. That's why I'm doing an OGTT, inducing hyperglycemia and giving excessive glucose. That must theoretically suppress the growth hormone production. You have to reduce the growth hormone release. Suppose even after doing this OGTT, if my growth hormone is still more than the cutoff which I expect it to be there, I can confirm it's a patient is having growth hormone excess state. So that's how OGTT is a very powerful confirmatory test. So do OGTT, you actually should have suppression of the growth hormone. So whether growth hormone suppressed or not, if your answer is yes, that is the growth hormone levels become less than 1 nanogram per ml after this OGTT, then you can rule out growth hormone excess once again. Suppose if it's not yet suppressed, which means the growth hormone levels are still more than 1 nanogram per ml, which means it's not suppressed despite giving a glucose load or OGTT, then I can confirm it's a growth hormone excess. It's confirmed. But I have to know the source. Usually it will be the pituitary source, but still I have to confirm, take an MRI. So if I see a mass, yes, most of the time this is the case. I will see a mass because many times it will be a slow growing, insidious onset disease, so it will be a big tumor most of the times. At least a sizable tumor you can detect. So I can confirm it's a pituitary source. It's a pituitary adenoma. If I don't see a mass, probably it comes from ectopic source. Very likely it is from ectopic source. So now I have to screen with CT scan of the chest and abdomen to rule out some small cell lung cancer or pancreatic neuroendocrine neoplasm. At the same time, it's wise also to check for the growth hormone releasing hormone levels. So which means that excessive growth hormone may not even be due to direct excess of growth hormone. It might be due to growth hormone releasing hormone also. So you have to check for that as well. So, but usually this is the case. You will see a mass and it will be a pituitary adenoma. That's the usual scenario. Fine. This is how we are going to find out growth hormone excess and confirm or localize the growth hormone excess. Clear? And one important thing that is for exams but not important clinically, that is called a paradoxical response to TRH is there. So what do you mean by this paradoxical response to TRH? When you inject a TRH, what do you expect? You might expect an increase in the TSH, or you might to an extent expect increase in the prolactin because TRH is stimulated to prolactin also. But in a patient who's having a growth hormone secreting pituitary adenoma, injecting TRH may result in excessive growth hormone secretion from the pituitary. That's called a paradoxical response to TRH. This happens probably due to, this is a tumor, isn't it? They might express aberrant receptors to TRH. So in response to TRH, they might release growth hormone. So when you give a TRH, you release growth hormone, that is likely to be a abnormal response. It's a paradoxical response to TRH. So this paradoxical response to TRH, if they ask you, usually you will see in a growth hormone secreting pituitary adenoma, or you can see in patients who are having anorexia nervosa, sometimes with anorexia nervosa, or you can also see in patients who are having a prolactinoma, sometimes, very rarely. Clear? So now this is how you work up a growth hormone excess, all right. Now let us move on to the treatment part, how you are going to manage this patient. Treatment-wise, the most important treatment that you are going to give, and the first line treatment is transfemoral surgery. Of course, we are dealing with a growth hormone secreting pituitary adenoma. Yes, which means the first line treatment for a growth hormone secreting pituitary adenoma must be a transfemoral surgery. I'll discuss you about the details of TSS in some time, but this is the first line treatment. Remember, this is the first line treatment. You have to resect the tumor because tumors tend to be really big in growth hormone secreting pituitary adenomas. At the same time, their growth hormone excess is going to cause excessive mortality. You don't have a very, very good treatment to suppress the growth hormone effectively. That's why the first line treatment is transfemoral surgery. After surgery, you have to see the response, assess the response. So you can divide where the patient has gone for remission or the patient has not gone for remission, no remission. When you call the patient has gone for remission? Based on two criteria. In the post-operative day number 1, which means the next day of surgery, see the growth hormone levels. If it is less than 1 nanogram per ml, obviously I can conclude the patient has a good surgery and they have gone for remission, and this indicates a less problem. And second way to assess is after 12 weeks, after the post-operative period, you check the serum IGF-1, which should be normal. At the same time, MRI should have no mass in the pituitary region. So these are the two criteria to tell that the patient is gone for remission. In this setting, no need to do anything further. Just do serum IGF-1 and follow it up annually. That's all. So you're going to just follow it up annually with serum IGF-1. That's it. And if the patient has not gone for remission, what are you going to do? Suppose if the patient has not gone for remission, in this setting, you have to start with a medical treatment, which means it's a failed surgery, it's not a good surgery. The patient had not had a good surgery, so go for the medical management. Medical treatment, the first line medical treatment in this condition is somatostatin receptor agonist, which means somatostatin is a very powerful inhibitor of growth hormone release. That's why we use this SSTRs. Remember, there are a lot of somatostatin receptor agonists that you can use here. The one is the ever common octreotide, but generally not preferred for this growth hormone excess states because it is more selective for receptor number 4 than receptor number 1. I told you this receptor number 4 is not seen in the pituitary. Is not at all seen in the pituitary in the first place. You have only 2 and 5 predominantly. So the octreotide is not a good choice. Then you have a drug called lanreotide, which is the preferred choice right now because this lanreotide is selective for receptor number 1 more than 4, which means they are not selective for the receptor number 4. They are actually selective for receptor number 1, which is actually seen in the pituitary. So that is why lanreotide is the preferred agent right now. And you have a third drug called pasireotide also, but pasireotide is again less preferred because they can worsen the hyperglycemia. So again, it's not that great or that effective as your lanreotide. Again, pasireotide is specific for receptor 1 than 4, but the receptor specificity and binding is not that great like lanreotide. So that's why for growth hormone excess, what we actually prefer is the lanreotide, SSTR of choice. Fine. The usual side effects of this SSTR agonists are going to be gastrointestinal side effects and gallstones. Clear? Gastrointestinal side effects means typically they produce nausea and vomiting. This can be seen with octreotide itself. It is not a must that they should be seen only in lanreotide or pasireotide. Any SSTR agonist can produce these side effects, and gallstones, very, very important side effects. Fine. Suppose if you have an inadequate response, again the goal is normalization of the serum IGF-1. So still it's ineffective. You don't get this and the response is inadequate. In this condition, you are going to go for growth hormone receptor antagonist. That is nothing but pegvisomant. Pegvisomant. Very, very important question for exam. Pegvisomant. This is a growth hormone receptor antagonist. But one thing you have to note about this is, I told you, once the growth hormone is released, they are going to have indirect effects and they are going to have direct effects. And remember, the indirect effects are mediated through IGF-1. Clear? remember, what is the mechanism of action of this growth hormone? Is through the growth hormone receptor. Growth hormone receptor. These are the growth hormone receptors. Which means when you give growth hormone receptor antagonist, when you are giving growth hormone receptor antagonist, your IGF-1 level will definitely decrease, which means your IGF-1 level will surely normalize. There's no doubt about that. But remember, this reducing IGF-1 can give a feedback to the hypothalamus and the pituitary. Hypothalamus and the pituitary, they can actually paradoxically increase the growth hormone levels. Even though this growth hormone receptor antagonist can result in reduction of IGF-1 and normalization of IGF-1, they can actually paradoxically increase the growth hormone production because of the feedback. That's why it is to be sure that it has to be given only after surgery. Don't give before surgery, otherwise it can even accelerate the tumor production, tumor size. But on the other hand, your somatostatin receptor agonist will actually reduce the growth hormone release itself. Because of that, they are going to reduce the IGF-1. So it's a different effect. So SSTR agonists reduce growth hormone as well as IGF-1, but whereas your pegvisomant will reduce the IGF-1, but they need not necessarily reduce the growth hormone. In fact, even they can increase the growth hormone levels. So always give pegvisomant along with SSTR agonists. That is again a very crucial point to know. Okay, but if they ask you the most powerful ever treatment that can normalize the serum IGF-1, answer is pegvisomant. Pegvisomant is the most effective treatment that can normalize the serum IGF-1, not even surgery, not even radiotherapy, not even SSTR agonist. Pegvisomant is the most powerful therapy that can normalize the serum IGF-1. After pegvisomant, if still you have a poor response, then you have to go for a pituitary radiotherapy only, which might result in pan-hypopituitarism. Clear? So very, very, very important treatment algorithm and treatment protocol. If they ask you shrinkage of the tumor is best achieved with, usually shrinkage of the size of the tumor is best achieved with, obviously surgery, and second with radiotherapy. These are the two things that is associated with maximal shrinkage of the tumor. But at the same time, if they ask you best treatment that can normalize the serum IGF-1, answer is pegvisomant. Be very clear. Okay. So now we have to see some idea about this transsphenoidal surgery. So what is the idea about this transsphenoidal surgery and what are things that you have to know? Remember, if they ask you the most common side effect of transsphenoidal surgery, answer will be CSF leak. And this is a transient CSF leak only. It's not a like permanent CSF leak. So you can get a CSF leak. This is the most common side effect. And the second most common side effect is diabetes insipidus, and this also tends to be usually transient. Remember, this CSF leak tends to be having more risk with, increased risk with actually acromegalics. I'll tell you why. Already I told you acromegaly patients will have excessive CSF production. So little raised ICP. Even though all transplant surgery patients have high risk of CSF leak, this acromegaly specifically has even more higher risk of getting this CSF leak. So transplant surgery, most common side effect is CSF leak. Second most common is diabetes insipidus and tends to be usually transient. But do remember, there is something called a triphasic response. There is something called a triphasic response after pituitary surgery or trauma. But remember, triphasic response is generally very rare. Usually get in less than 1 to 3% of the cases in the current era. You generally don't get this typical triphasic response. Most often you will end up with the first phase itself. You don't get all the three phases. All the three phases happens typically in less than 1 to 3%. So when you get more incidence of this triphasic response, if you go more towards the stalk, for example, if you have a tumor in the anterior pituitary, you do a transsphenoidal surgery, you just try to resect the tumor and come out. So the more you go towards the stalk, the more is the risk of this triphasic response. And because of the triphasic response, which I'm going to tell now, there is increased risk of permanent diabetes insipidus. Usually this does not happen really. Usually you will get only a transient diabetes insipidus. If you get a permanent diabetes insipidus, means you're going more towards the stalk of the pituitary. That's what it means. So that's why they don't do that, and currently they are going to only come just resecting the tumor and they come out. They don't go till the stalk, or they don't go any deeper, and they don't touch the stalk really. Okay. Fine. So what is the triphasic response? Let us see. Let us see with an image which is going to have a good idea. So you'll have a good idea. This is a procedure of a transfemoral surgery. You can see the TSS here. So why we do the TSS here? Because you know the pituitary is something just above the sphenoid sinus. So just by going through the nose and going into the sphenoid sinus, you can easily reach the pituitary. So instead of opening the entire skull and going into the brain and taking the pituitary out, this is a much easier and more of a less invasive approach compared to the craniotomy approach. This is how the pituitary looks. You know, like this is sphenoid sinus, what you see as a hollow cavity, and you can see a glistening structure. This is the dura mater. Remember, the moment you poke the dura mater, the tumor, this is a dura mater that is covering the pituitary in the sella turcica. Actually, they have broken the sella bone. You can see the borders of the broken sella bone here. They have broke down the sella bone, and the dura is actually now ready to be punctured. And the moment, if there is a pituitary tumor, the moment you puncture the dura mater above the sella, the tumor is going to pop out and you can resect it very easily. Clear? Because it's under pressure. That's it. So this is a view of a transfemoral surgery that you get. And you can see this is a classic triphasic response. So usually most of the time you get only phase number 1, you don't get phase number 2. What is a triphasic response? First, you can see this red is the ADH levels. The ADH levels actually drop dramatically, and because of that, the urine output increases. So which means it's the polyuric phase, initial polyuric phase. Because of the drop in the ADH, the urine output will increase. This is called a transient diabetes insipidus phase. That's called transient initial diabetes insipidus. What is the reason for this transient initial diabetes insipidus? That is due to the stalk edema. Stalk edema. Even if you don't resect the stalk, for example, let us take this, even if you don't go up to the stalk, resecting the pituitary tumor may result in edema of the pituitary stalk. Because of the edema of the pituitary stalk, the magnocellular neurons will have a conduction block because of the pressure there, and they cannot secrete the ADH through the posterior pituitary. So probably that is the reason why you're going to get this transient diabetes insipidus. That's due to stalk edema. Usually this lasts for 5 to 7 days approximately, and most of the patients will have only this phase. In the current era, only this phase will be there. They don't go for the second phase. Clear? It will be very transient. And in the second phase, if you see, the risk of getting second and third phase increases if you go more towards the stalk or you resect the stalk. Otherwise, you don't get this. So you can see their progress towards the second phase, where they're going to have increased ADH than normal, and because of that, they'll have a reduced urine output. And this is what we refer to as SADH phase, otherwise called antidiuretic phase. That is phase number 2. That is antidiuretic phase. Usually this phase length is variable. It can be happening for a variable duration of 2 to 14 days. Why they get this increased ADH? That is due to more severe damage, which means here you have actually damaged the magnocellular neurons. So once the magnocellular neurons are damaged, they degenerate. This magnocellular pathway neurons are going to degenerate now. Once they degenerate, they release all the stored ADH. The stored ADH will be released. Because they are releasing the stored ADH, it might result in a rise of ADH transiently, and again this is a transient phase where the patient may have reduced urine output because of SADH-like picture, antidiuretic phase. And now comes the final phase. The final phase where you have a permanent fall in ADH levels, permanent decrease in vasopressin levels, and because of that permanent increase in the urine output. This again permanent. So this third phase is permanent. So this is a complete degeneration of the magnocellular neurons. So permanent diabetes insipidus. This is the final phase. Fine. Remember the second and third phases are all the three phases. Triphasic response in the current era is very, very rare. You see in less than 1 to 3% of the cases. You don't generally get this because of the meticulous surgery we are doing right now. Only the first phase will be seen. Second and third phase is not seen in the current era. Clear? Remember, usually this is an irreversible phase. There is no turning back. The neurons will not regenerate again. It is a completely irreversible stage, and you have to supplement with desmopressin. So this will result in central diabetes insipidus. It's a permanent condition, and you have to treat this patient with desmopressin. Very, very important. Otherwise, patient will continue to lose the urine and they will have polyuria and polydipsia, and they'll suffer from a lot of issues. Okay. What are the other complications? I told you a lot of other complications. The two most important are the CSF leak and the transient diabetes insipidus. A few patients, like 1 to 3%, may go for this triphasic response if there is a extensive damage to the pituitary stalk. Apart from that, they can have or get meningitis, they can get vascular injury, or they can even go for a septal perforation. This is a nasal septal perforation, which can happen while going through the nose and breaking the sphenoid sinus. That time they can get septal perforation. So these are some of the complications of a transfemoral surgery, and understanding this transfemoral surgery is very, very important, again very crucial for exams, especially the CSF leak, most common side effect. It's having even more increased risk with acromegalic patients. And I think with this we have completed the growth hormone secreting pituitary adenoma also. And before going into the posterior pituitary, we can discuss about some of the men's syndromes and associated problems, and also the autoimmune polyendocrine syndromes. Then we'll move on to the posterior pituitary.